Okay, for segment number 2 here, I want to talk about some of the pharmacology and the idea of the magic bullet, right? We all know that people eat way too much. Is there a magic bullet there that we can simply eat a product or ingest a drug and it's going to suddenly fix whatever is going wrong as far as eating behavior? So we're going to kind of cover some of these different ones as far as the magic pill. Back about 20 years ago, why is it that long? I remember this actually. There was a pill called fen-phen, and it was fenfluramine. Basically, was the name of the product. Fen-phen was a product that basically worked with serotonin. We know after people eat that there's kind of a big release of serotonin in the brain. So the serotonin is kind of a satiety type of signal product. And so the idea is, well, if we can put serotonin in the brain, maybe that would cause people to eat less. And if you actually think about it, one of the side effects sometimes for people taking the depression drugs is depression drugs increase serotonin. One of the side effects is eating less, which sometimes is actually quite useful. Very recently, and you can see the background on this down below, the FDA actually approved its first new drug in many years, a drug called Belvig, which, if you look at it, is a very similar to fen-phen. It's a serotonin product. 5-hydroxytryptamine is a clue for serotonin. And notice they have the receptor agonist, that it's a receptor agonist for this receptor subtype, hoping to work on the appetite center of the brain. And they kind of give the FDA information that in obese patients with greater than 30 kilograms or overweight patients, that this product worked, and they got approval for this. So this is one product. There are quite a few other products that are being worked on. Sometimes you see info commercials for some of these things. There's a product, and I think your book talks about it, neuropeptide Y. They find that when neuropeptide Y is secreted up in the brain, in the hypothalamus, it seems to stimulate eating. So the idea would be, well, maybe you want to give something that blocks it. Leptin is another substance, seems to increase metabolism. So when organisms get leptin, they seem to burn more things up. And so maybe that could help as well. There's a substance that's released near the stomach, in the intestines. It's called cholecystokinin. And when it's released, it seems to cause nausea. And so the idea of causing nausea and getting people to eat less might be part of it. And then finally, ghrelin is a substance that if they're trying to develop antagonists for now, that might stop eating as well. So these are some of the products that are being worked on for FDA approval, but they're not quite there yet as far as going across the line and getting clinical trials and data that really supports it. So certainly in terms of our country, we do want a magic pill. But I think the next part of what I want to talk about here is perhaps the most important part. I don't know, when I think about eating behavior and I think about neurobiology, the basic problem that I see is all these models of neurobiology and rat behavior and so forth, they have no answer to the following situation. How can somebody be completely full of food and completely full and not want to eat another thing, and then all of a sudden there's a donut there and that person just woofs it down? My true belief about eating behavior is that eating behavior in humans is categorically different than what we see in terms of eating behavior in animals. I think for most animals, eating behavior is in fact a strongly biological event. I don't think it's that way with humans anymore. Have you watched the Food Channel before? The millions of dollars that are spent trying to get people to buy products, basically, advertise to buy products, as opposed to public health departments and medical groups trying to get people to stop eating these products. So we do have an obesity epidemic. People don't exercise nearly as much anymore. Food is all over the place. We have access to cheap food, many times very fattening food, very processed food. Companies want us to buy these products, and we do. We buy these products in large amounts, supersizing things all over the place. So every single holiday is a food holiday. So I think the business of food in terms of this country and selling products has been a winning situation for organizations but it's really led to a plumping up of our society in a major way. So I don't think these biological theories and these products are going to fix that by any stretch of the imagination. It's much more complicated than that. So there's an interesting model put forth in another textbook, and I wanted to use it here. It's called the leaky barrel model of eating and weight control. And if you want to, what you need to do here, if you type in leaky barrel model, you'll see a picture of a leaky barrel. Picture a big barrel, if you will, and picture a hose going into that barrel, if you will. So the idea is, if you're looking at the hose, the amount of the water that's actually in the hose is equivalent to the food that's coming into the system. So that makes sense, I think. The one I really like in this model, though, is the second one, the water pressure. How strongly is that water coming into the barrel? Well, that's the incentive value of the food. So if advertisers are doing a good job, and if everything is tasting so wonderfully delicious and signs are all over the place, and this fast food restaurant is advertising this and so on and so forth, that incentive value for the food is greatly enhanced. If you're in a good mood, you want to eat. If you're in a bad mood, you want to eat. So I think in our society now, the water pressure is very, very strong for food coming in. Number 3, water coming into the barrel is the amount of food actually consumed. So what actually comes in, the pressure versus the amount. So if you have a strong incentive value and there's a lot there, then you're going to get a lot of food coming into the barrel. The water in the barrel is actually the weight of the person. Now, the problem now, as opposed to 50 years ago, is we used to do a lot of exercise. So the barrel is leaky because that reflects how many calories are being burned up by metabolism. But now, we don't exercise except for special occasions, so we're not expending those calories. And then they actually have on this that the barrel is sitting on the hose, the bottom of the hose, which they call the satiety signal. But the thing we know these days is people's satiety signal can be on full force, and that still doesn't stop them from eating. And of course, the water coming out, as it says here, are the calories burned. So the leaky barrel model, I think, is a better idea as far as how to conceptualize eating behavior, that we still have all these biological elements determining what's coming in and so forth, but the psychology of eating is more important than ever, I would argue. So finally, with part D here, what's done? Well, you have medications working mostly with serotonergic systems here, fen-phen, and now, Belvig is going to be the one. Surgery, very interesting, and I printed out 1 or 2 things about surgery. This article in 2009 was actually a Cochrane review, C-O-C-H-R-A-N-E, where they look at all the research out in the field, and so it was a Cochrane review. And they basically found with this Cochrane review that weight loss surgery does work. But the question is, does it work? The question isn't, does it work? The question is, how does it work full term or long term? And so they found in this Cochrane review, it certainly does work to reduce weight for people. But then actually just a couple of months ago, a story came out that they actually did, these folks down in Durham, did an interesting study, and they basically found long term, it don't work. Because people go back to the same behavioral habits that they had before, and so the equation doesn't change. This really brings about the final example in our little outline here, which is the example of things like Weight Watchers, which it's very interesting. There are not that many people who participate in these types of programs. People are lazy. People don't have the motivation to do, and it's not easy to do, but cognitive behavioral programs are really the way to go here, because diet and exercise, monitoring your food intake, but it's difficult work to do. So hopefully with this particular presentation, you've gotten a sense of both the biology of eating behavior as well as the psychology. Hopefully you now understand a little bit more about the medications that are being used. I didn't touch upon absolutely everything in this chapter, but I wanted to go over some of this information with you. It looks like on the bottom of 352, I talk about fen-phen and serotonin. There are other cues as well that are sometimes used, but I really wanted to stick with the brain. Page 359 has cholecystokinin on it, CCK, but your book doesn't do a super good example of this. They have set point theory and lipostatic a little bit later, but I chose to cover it in the way I did. So in the end, this is what you need to know. I didn't talk too much about anorexia here. You can certainly read up on that. There's a lot of interesting stuff. It doesn't appear that anorexia is due primarily to a biological disorder. It seems that is due more to psychology that can have impacts on your biological system, especially in your hypothalamus, undoubtedly. So hopefully this makes sense to you. This will conclude the eating part of the presentation. I've got to go now. Got to go get a snack. Thank you for your patience, and I hope this has been okay for you to listen to. Bye-bye.